we are going to talk about children and children's problems, but first it will be good to think of how we could recognize problems in children of different ages. So, the first thing is that if we want to understand behavior, we have to realize that there is a very wide normal variation. This normal variation depends on a variety of factors. Different or abnormal behavior could be either a response to a stressful or abnormal situation. Let's think something like domestic violence, an abusive experience, conflict-related trauma, which after all we know a lot about in Sri Lanka, severe neglect, and then natural disasters like the tsunami. A response to a stressful abnormal situation is actually not abnormal. But on the other hand, you can have inappropriate or abnormal responses to a normal situation, and I'll go on to explain that a little bit more. First of all, let's think of what are the influences on a child and on a child's behavior, taking what's called an ecological perspective. So first of all, at the micro level, you have the child and the family. Then school is the neighborhood level, which is where the laser pointer was pointing at. And then you have the wider social environment, which is the macro level. So take in Sri Lanka, there's the child and the family. We all know that sometimes school is a very different environment. And then also that there will be a lot of different influences coming from the wider community and nationally. Then also, if you want to understand a child's behavior, you have to look at it in context, because behavior is a response to an event, an experience, or a feeling. So it varies according to the individual characteristics of the child. So a boy might behave in one way, a girl might behave in one way. The family or social context. What are the individual characteristics? They would include age. That's one of the most important things. Age will determine how children understand events, and it will determine how they react. Then there's gender. Again, we know that certainly in our society, girls are supposed to maybe behave in one way and boys are supposed to behave in another way. If a girl is very keen on playing games and running about and maybe playing cricket, in some families they will feel that's not girlish. But if a boy does that, they feel, that's right, he's a real boy. On the other hand, if the boy likes to arrange flowers and decorate the house, the family won't like it, they'll think this is not a real boy. If the girl does it, they're happy. Then the other thing is temperament. Now that is something really children are born with. We all know there are some children who are friendly, some children who are timid and are therefore not very easy with strangers. That would be their temperament. The very important thing is their developmental age and stage and level of intelligence. Say for instance, a child of 3 will be able to do certain things, and a child of 6 will be able to respond to an event in certain other things. Give you an example. If a child of 4 is told to go to the door and respond to a visitor, the mother might say, go and say that I am not there. And this child might go to the door and say, Amma said to say she is not here. And she might be very confused when the Amma then scolds her for having said it like that and not pretended. Now on the other hand, if a child of 9 goes to the door and says, Amma said to say that she is not here, he is doing it because he wants to put his mother into an embarrassing situation. Because he knows perfectly well that though the mother normally says, don't tell a lie, in this instance she is saying, tell a lie. So developmental age and stage. This is of course where children are of normal intelligence. The individual characteristics interact with family or social factors. So some families will like a very active child, other families will want a child who just sits and does nothing. So if we look at this diagram, this is just a diagrammatic way of looking at the different influences on behavior. And perhaps you can look at it when you are thinking of this and studying and work out the various influences that perhaps influence you. A little bit more on influences. So the developmental stage is what we call the level of maturation. It will determine how a child can understand and experience, feel, respond. So say children who are hungry, a baby will cry, a 2-year-old might ask, 6-year-old might go to the cupboard or the fridge and help themselves. Certainly 10-year-old will probably do that. Again, you remember what I said about temperament is the way a child tends to behave. It can be influenced by hereditary factors and by experience. And the temperament will influence personality development, which is something that happens later. Temperament doesn't change with age, but behavior can change if children learn to modify their behavior. So a child who tends to be not very friendly can be helped to become more friendly and less timid. Children who are irritable can, if they are helped, perhaps become less irritable, or at least learn not to show when they are irritated. So if we think of development, first we have to think of physical development. Growth, which is weight and height, speech, motor development, which includes also fine motor development. So that is motor development, ability to walk, stand, run, climb. Fine development, that is coordination. Learning to write needs good fine development. Self-help skills, learning to look after themselves. Emotional development, feelings. Social development, being able to behave appropriately in society. Cognitive development, think things through, problem solve, which is measured by looking at intelligence. And then finally, personality development. Personality development, which arises from temperament, occurs throughout childhood and early adolescence. So say we would not say that a child of 10 has a personality disorder. A teenager who is 18, yes, might have, because by then their personality would have been formed. Aspects of personality development are the ability to behave appropriately, understand moral behavior, understand one's own identity, that is not just who we are but what kind of person we are. Understand sexual identity, that will include sexuality, feelings of attraction, but also expectations of gender role. Now, we go on to how do we recognize a mental health problem. In general, with children, we tend to divide it into emotional or conduct. First thing is, it has to be inappropriate for the context and inappropriate for age and or developmental stage. By inappropriate, what we say is it might be too severe, too frequent, or persistently socially inappropriate or antisocial. So now say for instance, all of us might tell a lie sometimes. But if this is a persistent response, that's not appropriate. Now also the business about being inappropriate for age or development. So let me give you an example. If a boy of 12 lies on the floor and screams when he doesn't get his own way, and is of normal intelligence, that is inappropriate for age and development. On the other hand, if he is retarded with a mental age of 3 years, it will not be inappropriate for his developmental stage, because that type of behavior in a 3-year-old is normal. Another aspect is that the behavior needs to be either too frequent or too severe, resulting in interference with the child's development and experience. And then one could say, yes, this is a mental health problem. Behavior which may be a problem, there are several types, and these are divided into, very roughly, those behaviors that affect others. So, conduct problems, fighting, stealing, lying, disobedience. And those are also called externalizing behaviors, because the effect is on others. That doesn't mean there is no effect on the child, because sometimes the child might feel quite happy, or more often they will be angry, or they will be actually distressed. Then those that affect the child directly, so that is have the child's behavior: withdrawal, tearfulness, fearful or timid, poor appetite, poor sleep. Bedwetting and soiling, if it occurs after children have learnt bowel and bladder control, would also fall into this group. Bedwetting, as you know, would be called enuresis, and soiling encopresis. So all these second group of behaviors are described as emotional problems. Now, the differences between emotional and conduct problems are both, for instance, may result from distress, frustration, anger, neglect. The type of behavior the child will show will depend on individual variables. One important one, temperament, social norms, the child's context. So the differences are in the behavior seen, not necessarily in the feelings or the events that cause the behavior. Understanding the behavior and the factors leading to this behavior, child's context, and the individual variables will influence your direction of management. Because after all, if you are managing to help a child, you have to manage something that you can change. And there are a lot of other things that you can't change. Now let me describe a few feelings leading to change. 10-year-old Geeta clings to her father's pillow. She is withdrawn and won't play as before. Her mother said this has gone on for a year. She was very close to her father. One night when she was asleep on her father's bed, an intruder came in and shot and killed her father. Geeta eventually said she feels sad and guilty. She was too frightened to scream and feels that therefore she didn't save her father. Now what happened was, don't you know, when something happens in a family, other people come and say, this happened, why didn't somebody do something, why didn't this girl scream? She ultimately wouldn't talk about it, but she did some drawings for us. She was apparently good at drawing. I told her to draw her happiest and saddest day. She drew a beautiful drawing for the happiest day, or when she was chosen at Sinhalese New Year festival. Beautiful colors, crowds of people. Her saddest day, there was a bed, a pillow, a man lying on the bed, and a man standing next to the bed with a gun. The important thing was, she was not in the picture. And that gave a clue that she was wishing very much that she hadn't been there. And it was when we asked her about that she was able to say how guilty she felt. Now another example is of a child who was a bully in school And the teacher said she had made him a school leader because she felt sorry for him because his reading was very bad, though he was good at maths. So he wanted to be liked, but he bullied because he felt inferior. So what he also did was he used to steal money from home and go and buy sweets and give them to the children of the class so that they would like him. Now let's move on to actually how do you recognize a problem, because when working with children you do have to remember that you have to understand what's a problem for them, not what's a problem for the adults around them. So the first thing is, if a child is brought to you and people say they are worried about you, it's important to find out whether there is really a concern or whether the concern is because of the attitude of the person telling you, who might be the parent or the teacher or the other carer. So you have to do this by considering the child in his or her context. The main issues will be, try to get a comprehensive picture of the child in context. That is, what kind of child, family context, school context. Particularly you have to look at stress factors and strengths. Decision making about what is the problem, what may be the factors that have caused or contributed to the problem, what may be the most effective and feasible ways of producing positive change. So if you look at the information that you gather, and please don't get scared that this is a lot of information, because in fact you can sometimes gather it quite quickly. History. What is important is you try to get something from the child. In Sri Lanka particularly, we don't talk to children, we talk to the adults. Or the adults will come and say one thing, but actually if you ask the child, you might find that they have a different point of view. You have to try and get information from the child by talking to the child, by getting them to draw, playing with the child. And again, it's not difficult. Children are not like adults, they are honest generally. So they're actually quite fun to work with. You also need to talk to parents and school, if possible. Again, in Sri Lanka, sometimes it might be that they have come some distance to see you, so it may not be easy to talk to the school, but you have to try. And there are structured screening questionnaires such as the strengths and difficulties questionnaire that you can use to, and in fact there are Tamil and English versions and a Sinhala version from a website called Youth in Mind, which you can download and it's free. Assessment observation objective, that is, you look at the child with the family, and if it's possible, child in school, if it's practical. See, for instance, in the room, if the child sits close to the mother and doesn't look at the father, that tells you one thing. Then, if when you ask the mother what does he like to do in school, and she turns around and asks the child what do you like to do in school, that tells you something else. So you have to observe what goes on. But there are other assessments like psychological testing. So then, what is the context of a child's psychiatric history? Like any history, you look at the presenting problem. What is the problem, how long, what caused concern, and so on. Then previous concerns, which include behavioral, physical health, developmental. Current physical health concerns, because children might be miserable because they are ill. Developmental history. Now, school history. Of course, when you are taking a history, you have to use a bit of common sense. Supposing you are seeing a 16-year-old boy who has been first in class from the time he started school, you don't actually have to look at his early milestones, because you can be fairly sure that they were fine. On the other hand, if you are seeing a child of about 4 years, then those early milestones might be very important. If you are seeing a child who can't read, early milestones are very important. So you have to use a bit of common sense in this, but anyway. Then of course social history. Relationships within the family, outside the family, with adults, peers, interests and extracurricular activities. With adolescents, substance use is important. Of course you have to think, if you are asking the child, you have to think of how to ask the child. Children hate being asked, do you love your mother, do you love your father, and they know what they have to say is yes. So what you have to do is try other methods. I used to sometimes ask them to give marks to the people at home. That sometimes worked very well, but sometimes children would look at me, they knew what I was trying to do, and they'd give 10 to everybody. Or you ask them to draw and say who's in the row. Now there was a little boy who hated his younger brother, who was much more liked by the parents because he was an extrovert. And every room that he drew, I said, so where's Mali? Mali is not there. Which gave a clear idea that he was hoping that Mali definitely wouldn't be there. Family history, family structure, socio-cultural history, health history, and that includes asking about a history of mental health and substance misuse in the family. One important thing to remember is with history taking and management that you have to get consent and confidentiality. That's especially important if you are working with teenagers. And parents in Sri Lanka especially, or anywhere actually, find that difficult. They feel they own the child and therefore they have to know everything. At the same time, if you are talking to a child, you also have to explain, I will keep this confidential unless someone is doing something to you that they shouldn't do, in which case I will have to tell. And that's again a difficult one, but it's important. Assessment aspects. You look at the child's behavior, how they relate to others, do they look at you, what's their mood, do they appear sad, do they appear happy for no reason. Clinically assess their developmental maturation, their speech, communication skills, can they understand what you're asking, content of speech, are they relevant or are they irrelevant. Now that's especially important with adolescents. And then additional, you have to look, as I said, learning ability. Now sometimes you might have a psychologist who can do the Wechsler intelligence scale, or if you don't, you can use something called Raven's progressive matrices, which will give you some idea of their ability. And you might well ask, what is this all for? Is it useful? And I think the answer is yes, it is useful, because it's to facilitate what we call a formulation of the problem. It helps you first of all understand the behavior, consider the factors that may have predisposed or created vulnerability, precipitated the behavior, trigger factor, perpetuated or helped maintain the behavior. Positives, strengths in the child, family, social context. And that's important because you have to work with the family. With children, half the time you are working with the family. So this helps identification of what the problem is, what may be changed, and the direction of intervention. So if you remember Geeta, we can't bring her father back to life. That's not possible. So she has to be helped by helping her and her mother now. So when you plan an intervention, the task is what? Formulate, decide what is possible, then you begin doing what you plan to do, but you have to monitor and see, is it having an impact? If it's not having an impact, you might have to review what you decided and maybe change it. It's important to realize that you may have formed a plan and you might have to go back and say, actually that maybe was not the best plan, maybe I need to make another plan. So when we look at the formulation, what will be the common predisposing factors? Common ones are family history, quality of relationship between parents. Then also say a child has had, when at birth, an infection, or the mother had a cesarean section, that might, because of a delayed labor, that might influence the child's development. That would be a predisposing factor. Precipitating factors could be something in the child's behavior, something in the attendance at school, or some event, like in Geeta's case, the shooting of her father. Perpetuating factors may be the child's behavior, quality of relationship between parents, mother's parenting capacity. But those will also be strengths. The child's intelligence can be a strength, warmth in the family, good relationships with a family member, good relationships with some other person, those are all strengths. Now take for example, if a child has been abused and is able to tell her parents that she has been abused, say by her cousin brother, and the parents believe her, that shows strengths because the child was able to tell the family, and strengths that the family believed her. So you can use those strengths in helping the child further. Now let's think of an example. First of all though, just I'm going through the ways problems are described. Like I said, childhood problems, emotional disorder, and these are all the various subheadings of emotional disorder, which I hope you'll look at and read a bit more about. Then at any age you will have disorders like attention deficit disorder, ADHD, anxiety or phobia, obsessional compulsive disorder, depression, post-traumatic stress disorder, schizophrenia, bipolar disorder. I should have mentioned that under the childhood problems, yes, there was emotional disorder and also conduct disorder. Now, there are some other problems, developmental problems. So, specific developmental delays or disorders. One is delays in ability to read or learn maths or write. I mentioned a child who was bullying children because he was good at maths but couldn't read. So he may have had a specific developmental delay in terms of reading skills. Then some children have a specific speech delay. There is another condition, autism spectrum disorder, where there is a specific delay in social development. Then on the other hand, there is general developmental delay, which is also called mental retardation, where there are delays in all areas of development, and it might be mild, it might be moderate or severe. And it influences the way we understand the behavior of the child. Another thing to look at is the psychosocial situation. Family structure. A single parent or a reconstituted family, that is where a parent, mother or father has remarried after divorce, separation or death. The care structure, loss of parents or separation, inappropriate, working as a domestic servant, a refugee or as a child soldier, domestic violence, alcoholic parent, mentally ill parent, a history of physical or sexual abuse, societal trauma, particularly war, traumatic experience, for example, tsunami, All things that in Sri Lanka we are very familiar with. So again, if you look at the ICD-10 and we take what's called the multi-axial approach, you have all the psychiatric disorders which I talked about, where they are grouped according to the behavior and not the cause. So oppositional or conduct, emotional, sleep, feeding problems, trauma-related problems, attention, obsessional compulsive, eating disorders, anxiety, depression, psychotic illness. Then the next axis are the developmental difficulties, which includes autism spectrum disorder, or sometimes that's called pervasive developmental disorder. Then the third axis is general learning delay, mental retardation. Then physical illness. Don't forget that. Really severe physical illnesses, one of the common ones in Sri Lanka, bronchial asthma, can cause a lot of psychological problems in children. Type 1 diabetes. Then finally, difficult or abnormal psychosocial context. Let me give you a story. This 9-year-old girl is second in a family of 3, brought by parents who describe her as she is a little devil. She is always fighting with parents and older sister of 10 years and threatens to hit. But when we asked, actually the parents said she never does hit. Very bright, does well in school, has friends. Mother is a nurse, father is a PHI, public health inspector. No family issues. And she has a younger brother of 3. So the question is this a mental health problem, which is what the parents think it is, or is it as a result of family circumstances? Now, first of all, we know she is very bright and she does well in school. So there is no developmental delay there. Has friends, so she is social. So no difficulty of social development. So quite clearly there is something going on in the family that is causing this behavior. But she doesn't hit. She threatens, but she doesn't hit. Story continued. Actually, when I spoke to the little girl, she said, they don't love me. They love my sister, they love my brother, they don't love me. Now, you know, when we ask parents, do you love them? They say, oh, of course we love them. And we love them equally, of course we love them. But the thing is, you may love the children equally, but you don't treat them equally. It wouldn't be possible, say, to treat a girl of 9 and a boy of 3 the same way. So when we began to talk about it, the mother began to think that perhaps they didn't give her enough attention. So then she told me, when I come home, I carry the little brother. Now this child is already in Visakha and she's bright, and I don't have to do her homework, but I do her homework with the older sister, because the older sister has the scholarship exam. So this one actually doesn't get any individual attention. The individual attention is given to the other 2. Then the mother said that she gives birthday parties, but not for her, because her birthday party falls on Sinhalese and Tamil New Year. So actually the parents talked about it, and they realized that her view of things was different to theirs. And they altered what they were doing. And the problem disappeared. So let's look at now then principles of intervention for most problems. The most important thing is what we call psychoeducation, where you help the parent or the carer and the teacher understand the child's behavior, and then help the child understand what his or her problem is or situation. And you try to optimize the available ways for needs to be met, improve relationships the child has, allow expression of feelings in feasible and appropriate ways, help to normalize routines. Then you might have specific strategies depending on the diagnosis. But what you have to do is assess the impact by response of child and family, improvement in initial concerns, Is the child healthy, happy, growing and developing well? Are the child's needs met? Continue and follow up or reformulate. Now this is a basic structure that you follow, but then there are also specific strategies. There is no time today to talk about any of these in any kind of detail. I am just mentioning them. First of all, family approaches or family work, which has to happen all the time. Family therapy. Behavioral approaches, individually or groups. Behavior modification, like using a bell and pad for bedwetting. Behavior therapy, that is desensitization, for example, for a specific phobia. Now I'm sure you all are being taught that already by Professor Somasundaram and the team for adult disorders. Cognitive behavior therapy. This is particularly useful for anxiety or obsessive compulsive disorder and depression in young people. Individual work focusing on an expression of feelings, perhaps getting a child to tell or write a story or draw. Now using drawing, like we talked about Geeta who drew her feelings, is not art therapy, I do have to tell you. It is just using art to express feelings. Then use of psychotropic medication, I'm just going to go through that very quickly. But before that, CBT. As I said, it's a treatment of choice for some disorders in adolescence and very useful for post-traumatic stress. CBT works on changing thought processes which result from moods or emotions, and these may be fears, distortions, awareness of deficits, the thoughts that lead to the maintenance of symptomatology. Now, sometimes you have to forget the family context. Let me give you an example. 14-year-old Sammy lives with mother, younger half-sister, 1.5, and stepfather. He had been brought up by his maternal grandmother until he was 6 when she died. Then he was cared for by an uncle and aunt who physically abused him and neglected him. His mother brought him to live with her when he was 11. He was being brought up originally in another country. He goes to school but also has to do housework and take his baby sister to nursery every morning. His mother is very negative about him. He said he lies on his bed and looks at the ceiling and is someone who is tired of life. He wants to stay at home because of his little sister. Though he says maybe she will say she doesn't want me when she gets older. He's 14. Family work to change the family context was just not an issue and there wasn't time to do that. If we ever tried to change that family, it might have taken another 50 years, and by then it's too late for Sammy. So the point is, when children are teenagers, you have to think of, do you have to help them to cope and move on and make something of their life and more or less forget the family. So he needed help to cope with his negative experiences and then make plans for himself for a positive future. So that is when you forget the family. Psychotropic medication. In general, it is good to use it less with children and only if it's essential. Usually used in combination with other strategies, but for psychosis, it's the treatment of choice, and that's very important to remember. Symptomatic relief, for instance, in severe anxiety, only if you are using other strategies and the anxiety is very severe. Then disorder specific, certainly for attention deficit disorder, very severe depression, and as I said, psychotic illness. Sometimes also with severe obsessional compulsive. Epilepsy. Epilepsies will sometimes come, certainly in Sri Lanka and other countries, to a child psychiatric or also a psychiatrist, and that requires obviously medication. It's important to remember that when you are treating children, what you are trying to do is aim for well-being. Well-being. Now I am going to move on to a couple of specific disorders and then a situation. But first, these are the commonest types of psychotropic medication, and I suggest that you read these up in your pharmacology notes and textbook, and also I'm sure you've already been taught this for the use of in adults, and so I'm not going to spend time on this component, but these are the commonly used psychotropic drugs for children. I do have to say one thing, that is in relation to ADHD and methylphenidate. Quite a lot of people sometimes say, why do we want to give this? But it has side effects which are not actually very severe, and they've been well researched. The important thing to remember is ADHD also has a lot of side effects. If a child has severe ADHD, they don't learn, they fight, they get into trouble, they begin to feel unpopular, and the appropriate use of medication can completely change their experience, their learning, and their relationships. Now, the major neurodevelopmental disorders are, one thing is ADHD, attention deficit, the other is autistic spectrum. Sometimes they can exist together, but they are very different. Now, the incidence of autism is not so much going up as that people are getting better to recognize it, and also to recognize that there are mild forms, not only the most severe form. There's a genetic contribution, but it's also multivariate etiology like most psychiatric disorders. The main intervention is psychoeducation for family and child, and special education. The psychiatric intervention apart from that comes if there are comorbid disorders. With attention deficit, the prevalence is a lot higher. Again, there's a genetic influence as well as multivariate. It's been recognized now that although it's commonest in middle childhood, it can continue to adulthood. And that is a relatively recent bit of knowledge which is changing the understanding of some people in adulthood. There's a lot of epidemiology worldwide about this disorder, and the intervention is psychoeducation, behavioral, as well as psychopharmacological. The particular aspects of assessment for these children is, one is developmental history, school history and school observation, the use of specific questionnaires for ADHD to obtain information, which will include the strengths and difficulties questionnaire which I've talked to you about, and another one called the Connors. And with autistic spectrum, information about empathy, imaginative play, communication, rituals and obsessions, social relationships, social understanding, and questionnaires. For example, the autism screening questionnaire. The key diagnostic features with autistic spectrum, you might get delay and abnormalities of speech, a lack of expression, something called echolalia. I know a very bright medical student who was asked by his child psychiatric professor, "What is echolalia?" And he replied, "What is echolalia?" Which was his way of telling the professor that he knows what echolalia is. Social withdrawal, a lack of empathy, that is not understanding other people's feelings, and aloofness, rituals and obsessions. Many have associated learning delay or mental retardation. Some of them will be hyperactive. They may have epilepsy. But the important thing to remember is autistic spectrum is a spectrum. So these features are where it is a more severe type, but you can get with children of higher intelligence fewer symptoms. Then with ADHD, you have impulsivity, restlessness, poor concentration, might have associated tempers, might have learning delay and peer group difficulties because they are irritable and they are restless and they don't concentrate. See, as an example, there is a 10-year-old boy who is the second with two older sisters, referred as having outbursts, wringing his hands and crying. His mother said this is when he couldn't understand something even after repeated explanation. The school, he was good academically, but was lately having some difficulty with understanding concepts. For example, maths problems, where you say a man goes 6 miles and then he has to do something and do something else. He found those difficult. He became worried that he was stupid. He was very interested in trains and chooses routes for trips with the mother at weekends. This is his only interest. But you ask him about that, he knows everything about the trains, the train timetables, everything. Mother is a teacher, the two older sisters are social and getting on well in school. Father is a solitary person, no friends, and works as a graphics designer. Now this doesn't mean that all graphics designers are autistic, but anyway. When this boy was assessed, we found he fell into the autistic spectrum group. But it was mild because he was intelligent. And the intervention initially focused on helping him and his family understand the nature of his problem and also advising his school. Another example, 5-year-old boy was only child, brought by a mother who said he doesn't sit still, is always active. School complains that he is restless and not learning, not aggressive and has friends. He's been very active since he was 2. Grandmother says father was just the same. Mother finds he doesn't settle to anything at home and is always getting into trouble by pulling things, breaking things. He was assessed as ADHD and managed with behavioral strategies and medication, with psychoeducation to the family and school to manage his inattention. And he did very well. So the principles of management of these two conditions are that you have to have very careful assessment and a diagnosis. For both you require psychoeducation. For autistic spectrum, it's remedial learning and education. For ADHD, behavioral approaches and use of psychotropic medication. So it's just an example of two neurodevelopmental disorders where in fact they are different. Now, this last section is looking at trauma and disaster. What is important to remember is that the therapeutic needs of children and families after major disaster vary. The majority of children and young people after disaster, they develop adaptive coping and can manage with basic psychosocial support. A significant proportion of the rest can be helped by targeted community school or school-based activities. So for example, there were a group of teachers who were trained to develop group therapies of using CBT principles during the conflict, and in fact in the north of Sri Lanka. And that type of group therapy has been used in a number of countries where there has been either a disaster or a war, including Bosnia, Iran, Greece. A very small percentage will require specialist input. So that's why we have the pyramid in this way. Most people will manage and will cope so long as they have basic psychosocial support. What are the concerns that arise after traumatic events? One is intrafamilial. Interference with the family function and health status, increased domestic conflict, mental health problems. Depression, alcohol use increases. This is now well known in Sri Lanka, now very well known. Impact of quality of child care. Then impact on the children's function and health, physical health and mental health. Extrafamilial impacting on society. The societal impact of trauma or stressful situations. Destruction of physical environment, disorganization of support services, displacement, increased levels of violence, alcohol and substance abuse, sense of threat. Children are much more vulnerable to abuse in this situation. As you know, your Professor Somasundaram has a concept calling collective trauma. I'm sure he has talked to you about it. Now, interventions post-trauma, as I said, basic care and psychosocial needs, encourage development of a sense of security or predictability. I remember working with people for children and families in refugee camps saying that what was important is that the meals came at the same time every day. That if someone doing play activity, they came at the same time every day, so that children would begin to feel that they had some kind of security. We found that provided schools were open, provided a lot of security and sense of security for children. Then help children express their feelings. Specific help where behavior disturbance is severe might be needed. If the behavior disturbance is severe, it continues and interferes with day-to-day function. In conclusion, if you're adults working with children, it's important to look at events from the child's point of view. This will help you understand behavior. Try to think of it from the child's point of view, not from the adult's point of view. But of course, having information about the family context is absolutely necessary, and also the characteristics of the child. Age, developmental stage. Working with children is rewarding and enjoyable. But where you are working in difficult situations where perhaps there's been a lot of trauma, you should be able to discuss your experiences with others. And this will also help in developing appropriate ways of dealing with these problems. I've come to the end of this particular talk, and I'm sure if you have any questions, you'll be able to ask your lecturers about it, and I hope you learn something from this lecture.